Hello and welcome to the International Forum on Quality and Safety in Healthcare here in Paris. We're here from East London NHS Foundation Trust in the UK. My name is James Innes. I'm the Quality Improvement Programme Manager for the Trust, and with me is my colleague Marie Gabriel, Trust Chair. And we're really delighted to introduce the following people.
I'm Jim Anderson, delighted to be here. Thank you for the invitation. I was the former CEO of Cincinnati Children's Hospital for about 13 years, and prior to that was chairman of the board of trustees. And during that time, practiced law basically in Cincinnati in the corporate field. And interestingly, did not expect to become involved with healthcare, but the way events turned out, and my predecessor was retiring. The board at that time decided someone that looked like me with my experience would be useful as CEO. So I really don't come from healthcare, but kind of parachuted in, and as a result of that, had virtually no knowledge of how healthcare was supposed to work. And which kind of unleashed me to look at things with a fresh eye, unburdened by facts, and so it's kind of a maverick position, and a lot of fun.
I'm Gary Kaplan. I'm an internal medicine physician at Virginia Mason Medical Center in Seattle, Washington. I've been at Virginia Mason 36 years. And have had the privilege over the last 14 years of serving as chairman and CEO of the health system. It's been a great opportunity to lead in an organization that's totally committed to quality as our core strategy. We are the furthest along of anybody in the world applying the Toyota production lean management system to healthcare, and we're continuing to learn every day how we can do that even better. Nice to be here. Thanks for the invitation.
Steve Swenson. I'm from Mayo Clinic. Mayo Clinic was actually founded by an Englishman, William Worrell Mayo, 150 years ago. I've been at Mayo 32 years, and my current role is the medical director for leadership and organization development. Mayo's physician-led. We partner with administrators so that the physicians can remain in the practice part-time, seeing patients, doing research and education. And before that, I was head of quality for our 24 hospitals in 7 states.
Good. Well, I'll tell you a little bit about our trust. So East London NHS Foundation Trust provides mental health, community health and specialist services to a number of boroughs within London and also outside of London as well. We serve an extremely diverse area, ethnically, culturally and socio-economically. We operate from around 70 inpatient and community sites. We have a little over 770 general and specialist inpatient beds, and we employ around about 3,700 permanent staff. Now the Trust is really well regarded for quality at the moment. We've got a number of awards, and we're in a very good place. However, we also recognise that still variation exists in quality, and this is through different services within the Trust, but also even within the same service over time. And we recognise that the only way forward is with a new approach to quality. And as such, the Trust has set itself a new mission to provide the highest quality mental health and community care in England by 2020. And underpinning that, we have 2 initial stretch aims, one looking at reducing harm by 30% every year, and the other looking at all patients getting the right care in the right place at the right time. And in the past year, we've done an awful lot of work to sort of help support that. So we've set up a central quality improvement programme team to coordinate this programme and also act as the organisation's internal resource for quality improvement methodology. We've done a tremendous amount of work to ensure that all our levers and systems in the Trust are aligned to ensure that we can see that quality improvement work flourishes. We're doing an awful lot of work to engage as many patients and staff as possible. And finally, we've just become strategic partners with the Institute for Healthcare Improvement, and we're really focusing on training staff at scale and at pace to give them the skills to do this. So I guess in this panel discussion, we're going to focus on how to implement an organisation-wide quality improvement programme. And I think we should go on to ask some questions.
All right, so I'd like to ask a question of you, Gary, as one chair to another. What do you think the role of the board is in quality improvement, and what kind of information, key information, would you want to put in front of them?
Thank you for the question, and it's critically important. I think that we have a history, I think, of underappreciating and under-leveraging the role of governance in our healthcare institutions. And I think the board has a very central role. In the United States, in our institutions, not-for-profit healthcare, the board really is the entity that holds the organization in trust for the community. And our boards are made up of community leaders from large corporations, in our case in Seattle, from Boeing, Microsoft, Starbucks, community leaders. And our board believes, and I believe, that actually the ultimate accountability for the quality and safety of the care provided in the institution rests with the board. Historically, the board delegates that to the medical staff and the medical staff structure and medical staff committees, but the board ultimately is the final authority and finally accountable. We take that very seriously, so that our board dashboard, for example, contains big dot metrics such as unadjusted mortality in real time, very recent, very current data, and reviews that type of information on a regular basis at all and in between board meetings. But we've also done something interesting that I think is potentially helpful to other organizations, and that is our Board Quality Oversight Committee has taken on the role of reviewing our most serious patient safety events, what we call our red patient safety alerts. And so we're very transparent with our board, and the red patient safety alerts must be reviewed and approved by the Board Oversight Committee before they are deemed to be mistake-proofed. So it's quite uncanny to have the chief of surgery come into a boardroom, say, we've been working on this, we've done root cause analysis, we've made all the improvements, it's now mistake-proofed, and 10% of the time, the public board members send it back for more work. And then finally, many know about our decision to be transparent in 2004 after the death of Mary McClinton, who died of a preventable error at Virginia Mason. We would not have been able to do that without the full support of the board. So the board sets the tone. The board is right there with us every step in the way in our core strategy, which is quality. And then the board has a very active role to play on an ongoing basis.
Well, thank you. I'd like to ask a question of you, Jim.
Sure.
Service users and carers are a really important part and partners in decision-making within our trust. And I wondered how you've made sure they're equal partners in implementing quality improvement within your organisation.
Who was the important partner?
Service users and carers.
Okay. One thing let me just add to Gary's comment, because I would second all the elements that he's done. And one of the things I found was that in order to embark on a safety-oriented program that is effective, the institution needs to take risk. And risk is really, risk-taking needs to be embraced by the board. Once the board embraces the notion that risk in support of transformational change to improve quality, once that decision is taken and it becomes known and credible, then it unleashes an enormous amount of energy and interest and action by literally everyone over time in the organization in support of those steps that are required to make the place a different place from the standpoint of safety. And this notion of risk, healthcare I found was very risk averse, and so explicitly addressing risk, dealing with it, putting it in a context of its essentiality in order to make change that's important, that will really change the outcome, is a very important message to communicate through the organization. Your question in terms of connecting the other participants in the system, Where we started was with a vision statement, and what we found when I first became board chair is that we all had a good sense of the activities we were engaged in, of clinical care, research, and education, but none of us had an ability to describe the overarching purpose of the organization, and to which these three activities would be tied, and wanted to advance knowledge and accomplish things. So we spent 2 years brainstorming about what a vision should be, and came up with 8 words after 2 years of being committing to being a leader in improving child health. And once we went through that process, and really the process was more important than the actual words, all of the important constituencies understood why we were committing to that, and embraced that as an appropriately aspirational goal. And with that, then our ability as senior executives to connect with physicians and nurses and other business people in pursuit of at least a very broad, high-level goal enabled them to articulate what their role should be and would be, and what they would commit to in order to advance their piece of that aggregate vision. So starting with the big vision, and then working down from the vision to a strategic plan to action plans by each of the units in support of a vision that was developed in consultation with each of the constituencies, it is what we found worked. And of course, on a very practical level within that, the idea of going after the low-hanging fruit first, because there will be a full range of enthusiasm or lack of enthusiasm expressed, and to support those who are enthusiastic about making transformational change and all the process associated with that, to deliver results, and then set that as an example, and that tends to draw in others. And it's a complicated system. There are a lot of moving parts, and you have to pay attention with a very practical mind applied to which parts give you opportunity, and then take advantage of it.
Thank you.
Great. My question's for Steve. I mentioned earlier on that we're a very geographically diverse organisation, spreading across a number of sites, 70 community and inpatient sites. So what challenges do you think we may encounter, and have you got any ideas how we could tackle those?
That's a real exciting opportunity for thousands and thousands of people in their communities and their families. Mayo Clinic is dispersed too. We have 61,000 staff in 24 hospitals in 7 states and 80-some clinics. So the way we've approached this is I think what you're doing. You start with a bold vision. It's very exciting to look at the audacity of saying we're going to reduce harm 30% this year and next year and the year after, and that all care will be in the right place and the right time and the right way. So what I've found, what we found at Mayo is beautiful vision. We need absolute specificity on how you define harm and how you define the right care, the right place, the right time, so that you can measure that at each of the 70 communities in exactly the same way and compare it transparently across the whole trust, so that the leaders of those 70 clinical areas has unambiguous understanding that these are the measures they're accountable for. And the leadership of the trust, when they visit them, and it has to be a face-to-face visit for each of those 70 leaders, you shake their hand, and the first thing you talk about is harm, and the second thing you talk about is the right care, the right place, the right time. And you've got measures to compare to the other 69 clinical areas and say, why are you number 68? Or what are you doing? And then you build this community of social capital, of trust and interconnectedness, so colleagues can say, wow, what are they doing up in this northeast part of the trust? They're knocking it off the charts. So how can we learn from them in a way that's productive and gets the front line involved? The last thing I'll say is you've got this cascade of a wonderful strategy, operational plan, measurements to the 70 communities. We've got to engage the nurses and the pharmacists and the docs and administrators there, so they are partners in this. They feel like they're architects instead of construction workers. And so what we've done is we analyze every death at Mayo Clinic in a templated way, looking for system issues, and every serious harm event we analyze in a templated way with the frontline docs, nurses, pharmacists, administrators to say, did we have a protocol? Do we have a pathway? Did we have a policy? Was it world class? And did we follow it? And if we didn't, we should have one. And if it wasn't world class, we should fix it. And if it wasn't followed, then we would address the issues with that, so that you have this opportunity to continually improve the reliability of care, and it's owned by the front line, not by back office quality experts.
That's a really helpful question, Steve. Thank you very much. Or answer, in fact. Okay, my next question is for Gary. How do you get the right balance between assurance and performance management, research and innovation, and continuous improvement?
Anything else that we want to?
Happiness general.
I mean, I think you highlight, in quality assurance and so the important elements of assuring accountability that you actually are doing what you say you're doing, and continuous, and as Steve references, continuously improving. I think the way you strike that balance is by embedding it deeply into the culture, to actually have all of those things be everybody's job. Now, that may sound overly simplistic or next to impossible, and that's not to say you don't need quality improvement specialists or resources, or you don't need quality assurance folks, so you don't need an R&D function. But frankly, when you build that into the culture, it becomes everybody's responsibility. And so one of the things we've learned, which was surprising to many, was that many of the pathways to higher quality, safer care are the same pathways to lower cost. They serve as platforms for innovation and for research, where many thought that standard work would stifle creativity and stifle innovation. Just the opposite has been true. And so what we've worked hard, starting at the very top of the organization, and deeply embedding it in our leadership mentality, but also really focusing on the sharp end of care, where frontline staff are delivering, face-to-face care with patients every day. We ask our people to come to work with two jobs, and we've talked about this before, to do their job and improve their job. And that if that's the mindset, then quality improvement and the audit function, the ensuring we do what we say we're going to do, as well as research and innovation, really become part of daily work life and improvement. And I think that that's possible. And not everybody's going to be the academic champion. Not everybody's going to publish original peer-reviewed research. But we create the environment for that. And by taking waste out of processes, which is a cornerstone of our management method, you actually create time. And then people actually have time to do many of the things that are important, both professionally and personally. And I think that creates a healthy culture.
Go ahead. Well, if I could add to that, I wouldn't worry too much about the right balance. Yeah. What I would worry about is everybody pushing their frontier? And do they have the resources to do it? Have you removed the barriers from success or of success from their pathway? And certainly celebrate their progress. And over time, some will be better at this than others, and that's worthy of great celebration. Some will not be where they should be, and that's worthy of more intense activity. But I think there is no exact balance to be achieved. There is a very pragmatic pathway that says where you have opportunity, we want to help you execute. And transform the way healthcare is delivered.
So what I hear from what you're proposing, and what the trust is doing, very exciting, is that you've already determined the balance. The balance is going to be on harm and the right care, the right place, the right time. So you've already got the balance. Where organizations fail in situations where they're looking at bold transformational change is that they don't stop doing something. There's limited bandwidth for these 70 places in the trust and the folks that lead them, and you've got to stop doing something and saying, we're focusing on these two inspiring initiatives, and all hands on deck are going to be related to these. This is what the top leadership of the trust will focus on. It's what we'll measure. There may be some other things you have to do for legal reasons or whatever, but the improvement work has to be aligned with the trust's priorities. It can't be local, with few exceptions. If you're going to achieve this wonderful vision, you got to be focused and disciplined and stop doing something.
Really inspiring. Thank you very much. I wanted to ask Steve a specific question about building a business case, if you like, for quality improvement. So can continuous quality improvement realise cash releasing savings when 70% of our costs are staff costs, and we don't want to make our staff redundant?
This is an area where the healthcare business sector is a generation behind the others. For decades, the other business sectors in the world have understood that if you drive out variation and waste and defects of care or process or delivery or whatever you're making, cars or delivering packages or caring for patients, that you improve reliability, quality and value, and you save money. Because all three of those things cost you money. And so the biggest challenge, one of the biggest challenges of engaging the top leadership in organizations is connecting value creation, performance improvement with the bottom line. Most leaders in America anyway, in healthcare, look at quality as an important expense, when in fact, if it's done well, it is a business strategy that rolls directly to the bottom line. So we've studied this at Mayo and published work on it. We have a $48 million 3-year rolling average return on investment. We can guarantee a 5-to-1 return on investment, hard dollar savings. For every $1 million we invest, we can deliver $5 million to the bottom line. This isn't something quality folks made up. Co-author on this was our Chief Financial Officer, Jeff Bolton, who's now our Chief Administrative Officer. These are real solid financial dividends from improving the care of patients. You don't talk to doctors, nurses, and pharmacists and say, we're going to make more money by improving the care. You say, we're going to save lives and improve the health of these families. But the leaders of the institution need to understand there's a connection to the bottom line. When you get beyond the compulsories, if all you do is report 135 measures to the national organizations, then it is an expense. But if you get into the next phase of what you're talking about with the harm and the right care, the right place, right time, then you can do it the right way with decades-old systems engineering principles. You can deliver it.
Brilliant. Thank you so much.
I've got another question for either of you too. And this is really about continuous improvement. Has a lot of measurement in it, so you can end up with lots of information. So I'm quite interested in how do you pick the right information and how do you measure things as integral as compassion or, for example, innovation? Did you want to go first?
Well, let me start and pass it around because I'm sure we all have experience with this. When we started various projects, we were never exactly sure what information we either needed or wanted or what the endpoint would be. We knew we wanted better outcomes, and we could measure the current outcomes, and we wanted to improve various dimensions of those. And among those outcomes was patient satisfaction. Cost was another component of the outcome. And I think a comfort level with not knowing everything you're going to need when you start is absolutely essential to the process of execution on these. And we got to say to each other frequently that you've got to start before you're ready, and to try to relieve people from the burden of feeling obliged to have everything totally thought out that would describe the pathway to improvement. So it's reasonably easy to come up with some rough parameters that look relevant to the improvement at the beginning. And as a part of that commitment should be a continued commitment to course correction and change of what that data is, and then changing the infrastructure to accumulate that data. So my advice, for you and for us was to come up with a responsible set of parameters that would define the goals you wanted to achieve on the pathway, and then get started. And feel free to change them as you go along. And increasingly the range would narrow, and over time you'd come up with some very useful, very effective numbers, and that would in turn educate others about the kind of process to go through, and also what the various stages look like, which accelerated the point at which they started, and then they, through their experience, could teach others. So I think the notion of getting started before you have all the answers is a really important one, and then being nimble, agile, flexible, willing to change, and in absolute, unambiguous, tenacious pursuit of improvement is what would characterize a group that was effective.
Really useful. Do you have anything to add? Okay.
I think that metrics are critically important. I think metrics must be our ally in understanding our work and measuring our journey to continuously improve. They can also become our enemy. And actually, we've spent a lot of time talking about the hundreds of metrics that are now in the public domain that organizations are reporting on. And we are thinking more in Virginia Mason about what are the vital few. But your question about compassion and how do you measure some of the softer aspects of, I would say, patient experience and staff experience. Yes. And I think you can't have outstanding patient experience if you also don't have strong staff engagement and staff partnership. So we work hard to measure both. And I know my colleagues' organizations do as well. We've also borrowed from some work that was actually pioneered in the UK on what's called experience-based design. Came Paul Plesic, who worked at the NHS Institute, did some of the early research on this. But it's about capturing the feelings and the emotions of our patients and of our staff. And so we actually, in real time, give our patients surveys around their emotional content. We've actually published some of this work now with words that are reproducibly indicative of positive, neutral, or negative feelings. How did it feel lying on the stretcher waiting to go into the operating room? Cold, lonely, abandoned, or warm, nurtured, cared for? Likewise, our staff. How did it feel at the beginning of the day going to work in such X department? Well, I felt energized and ready to go. How did it feel at the end of the day? Beaten down, disillusioned, tired. And it's very powerful to use those kinds of measurements then as part of the catalyst to improvement and to true patient-centered process design. So we found it quite helpful, and we're continuing to refine that and hope to take it to the next level.
It's really useful.
I want to underscore what Gary said about the focusing on the vital few. And so with this initiative that you're undergoing for transformation in the trust, you should have no more than 5 metrics that you talk about with those 70 leaders. And compassion's great, but it's not related to the 2 major initiatives, so it shouldn't be one of the 5. If you want something on that side of it, it should be psychological safety, or maybe teamwork, or something that would relate to preventing harm, or the right care at the right time, the right place. But you can't have more than 5 metrics if you're going to be effective, and that's the conversation you have with those 70 leaders, not about anything else.
That's so useful.
Really good.
So yeah. So Steve, if you could go back in time and be at the very beginning of your quality improvement program, what would you do differently?
I tell you, we've made hundreds of mistakes that if you've got 3 days, I'd be happy to. I tell you, one of the best things that we did, I think you're doing now. And so when I was asked to lead quality at Mayo Clinic with James Dilling, my administrative partner, and then our team across 24 hospitals, we went to the best places to understand what they did. So we visited with Gary Kaplan. We had him come as a visiting professor. We went to Salt Lake City and visited with Brent James. We went to IHI and visited with Maureen Bisignano, Don Nolan, and Don Berwick. And we put together what we think was a robust plan that we stole from the best people in the world because they gave them to us. And so I think what you're doing now is looking at learning from the failures and successes from folks all over the planet, and then so vicariously getting the mistakes of others. And you'll stumble if you're human, but up front you will have. You'll have the humility of saying, we'd like to get some advice and help and learn from others' experiences so you don't have to suffer the same agony.
Thank you for your honesty. Did you want to?
Yeah. Gary, I've got a question for you. How have you engaged the skeptics in quality?
Skeptics?
Yeah.
Skeptics.
How do you...
Oh, you don't have any?
No, I think, well, first of all, and I think Jim's already alluded to this, but healthcare is historically quite change averse. And, the status quo is very much like gravity. And, it just keeps people in place. That's why I like particularly the metaphor that Maureen has been, and others have been using in escape velocity. How do you really overcome the forces of gravity and status quo? And so, inevitably, with every major change initiative, there will be skeptics. On our journey, in our early years of our work, 12, 13, 14 years ago, I would say that about 10% of our group was were champions, really early adopters. And 10% were heavily barricaded in their skepticism. And the other 80% were, this will pass and it will go away. And so my approach then, some would say to our detriment, was to try to bring everybody along. I've been at my organization, like Steve, we're lifers in our organizations. I've been there 36 years. So many of these people were my teachers, my mentors, my friends, colleagues. I wanted everybody to come. And one of the things I should have done better is realize sooner that not everybody could come. And so I say not everybody must be a champion, but you cannot be a barrier. So that if a department using evidence-based medicine, best practice research, they determine that this is the best practice and this is the way we are going to do things. If there's one outlier in that department, that person can be a real barrier to the upstream suppliers of their processes and to the downstream recipient of their work. That can create defects and errors. It can demoralize staff who are trying to do their very best using best practice. So we said you can't be a champion, it can't be a barrier. And that then means we need rigor around performance management. We need rigor around crucial conversations. We need to be willing to try to bring everybody along and create a pathway where people can come and do their best work, but also recognize that if you really want to make the transformative leaps as organizations, there are some lines in the sand around what needs to happen. That's one of the hardest things to do as a senior leader, I think.
The other thing to do, that's a beautiful illustration, and Gary has led this better than anybody in the world. The other part of it is, for the skeptics, is show them the numbers. Show them their individual numbers, show them their department numbers, their division numbers, and compare those numbers with the other 69 areas and say, are you happy with this level of harm? And are we giving the best care at the best place in the best time for this patient? And every doc and nurse and pharmacist administrator wants to get an A, and if they're not getting an A by good data that's compared, benchmarked internally to your 70 sites, that gets a lot of, part of the change is to get people uncomfortable with the status quo. You've already got this vision that's exciting. So you see, you compel them with a vision, make them uncomfortable with their own numbers for their clinic or their individual, and then almost everybody come along. Some of them will have to get off the boat or the bus.
Hopefully not too many. One thing I just wanted to add, it reminded me, one of the things we've worked hard on is creating self-discovery experiences for the skeptics. So helping them convincing them to at a minimum be on an improvement team and suddenly realize that in this improvement work are answers, solutions to problems or challenges they face in their daily work life. Or we would take opinion leaders who were very skeptical on our early trips to Japan, and they would come home being champions. And so I think it's finding those opportunities for them to touch the method, and then the facts that they see as part of that process become compelling. And I think for physicians and nurses, pharmacists, we like data.
Yeah. And the good news is that people don't go into healthcare unless they have some significant part of them that wants to improve the health of patients. And so unlike many other industries, the base presumption is in favor of the kind of transformational work that we're talking about. Then add to that the mechanisms to actually deliver what they presumably want to do, and the resources to accomplish that, and the celebration and the education, skeptics by and large come along. There is a group, as we've all alluded to, though, that are, for whatever reasons, not able to appreciate or constructively engage in that process, and inevitably they either find some other part of work within or outside the institution, and understanding that that's a likelihood is a part of the aggregate management process that should be just as transparent as other parts.
Thank you. Well, I think this has been a tremendous session. I mean, I think we both found it very, very useful. We're really, really excited about the project, the programme we're embarking on, and I think it's been some really sound advice. So on behalf of myself and Maria, I'd just like to say thank you to Jim, to Gary, and to Steve. Thank you very much.
Thank you.
We wish you the best of luck.
Thank you so much.
Thank you.
Thank you. Bye-bye.